Good morning, everyone. Welcome to today's town hall on Ochsner's cancer care facilities. I am Kim Holden, former evening news anchor for Fox 8 WVUE, and I will be your moderator today. We have four panelists today who will share their areas of expertise, their best practices, and how the Ochsner Cancer Institute's culture of collaboration leads to superior outcomes. They are Dr. Brian Moore. Dr. Moore is the medical director at Ochsner Cancer Institute. Thanks for being here this morning.
Thank you.
Dr.
Happy to be here.
Yes, we are so happy to have you. Dr. Jay Brooks, Chair of Hematology, Oncology at Ochsner Cancer Care Center in Baton Rouge. Thank you so much, Dr. Brooks.
Thank you.
Dr. Philip Pruitt, Hematology and Oncology at Ochsner Lafayette General. Thanks for joining us this morning.
Thanks for having me.
And last but not least, Dr. Nicholas Torek, a psychologist at St. Tammany Cancer Center, which is a campus of Ochsner Medical Center.
Good morning. Thank you for having me.
Absolutely. The Ochsner Cancer Center Institute has cared for patients from all 50 states and 28 countries at its comprehensive cancer centers in Baton Rouge, New Orleans, St. Tammany Parish, Lafayette, and in North Louisiana. In 2021, Ochsner served more than 34,000 adult and pediatric cancer patients and completed more than 300,000 screenings for breast, colon, cervical, and other cancers. The Ochsner Cancer Institute delivers advanced technology and treatment options such as precision therapies, early tumor detection programs, and the largest clinical trials network in Louisiana so that patients don't have to leave the state for high quality cancer care. The Institute's integrative oncology services program, when combined with traditional therapy, treat the whole patient and not just the cancer. So we are going to ask these experts to dive a little deeper into cancer care at Ochsner, and we're going to begin with the holistic approach. So Dr. Moore, we'll start with you. Ochsner has embraced a multidisciplinary method of treatment for cancer patients. I guess, what is the reasoning behind this? What kind of clinicians are involved in a patient's treatment?
Well, that's a great question. First and foremost, cancer is a complex disease, and we learn more and more about it every day. There are newer treatments that come online, and it's almost impossible for one physician or one care provider to know everything about how to treat a different kind of cancer. And so the team is really essential. And so cancer care really becomes a team sport. And that's what's great about working here at Ochsner, because we have subspecialty expertise on the medical oncology side, where you have, say someone who knows more about breast cancer, is a little more focused on the care of breast cancer patients than, say, someone else. Surgical oncologists with advanced training and focused practices in dealing with cancers of specific parts of the body. I'm a head and neck cancer surgeon, for example. Radiation oncologists who often have subspecialty areas of expertise as well. And then you add in the other members of the team, psychologists such as Dr. Torek. We have nutritionists, we have social workers, we have nurse navigators that really help patients get through this complex and really complicated event in their life that's often disruptive. So, the simple answer to your question is that we really feel that it's the standard of care.
Okay. And Dr. Torek, you mentioned with patients' mental health. Aside from treating the actual cancer, how does Ochsner address a patient's mental health needs?
That's fantastic question, Kim. I'll say that when an individual receives a cancer diagnosis, there's a lot more to consider than just treating the disease. We know that we here at Ochsner offer programs and specialties with our oncology teams that support patients through treatment, through diagnosis, treatment, and survivorship, providing side effect relief, psychological support, like Dr. Moore said, nutritional guidance as well, and many other benefits. I can say that we understand that the stress that comes with cancer diagnosis does not disappear after that first diagnosis and initial appointment. Every new success or every new difficulty brings new concerns, new questions to both patients, their caregivers, and their loved ones. And psychological services are here and provided to really help that whole unit to manage this stress. I can say that our oncology psychologists, well, we're exactly that. We're specialized. We're psychologists, but specialized in oncology care, meaning we know the cancer biology, we understand treatment side effects, and we're available to meet with anyone in that family unit, whether it be the patient, the caregiver, the mom, the dad, the daughter, the son, and provide a more comprehensive approach to managing illness.
And that is a really good point, because it isn't just the patient's psychology that is affected when there's a cancer diagnosis. So, yeah, that is a very, very good point. And Dr. Brooks, technology today is so far advanced than it used to be. How does Ochsner use technology such as electronic medical records, also digital apps, to really try to improve communication and collaboration among doctors, as well as between the patients and their care team?
So the word you've heard from two previous speakers is it's a team sport. And so teams work together. Teams need to be able to communicate. When I came to Ochsner many years ago, we used a common paper record. It evolved to an electronic record. In 2010, the system began to convert to Epic, so that everyone across our system in every specialty sees the same thing on a patient. And most people take that for granted, but when you look at cancer care through the area of the country, many people are on 4 and 5 different electronic records that don't talk to each other. That's not the way it is here. Everybody sees everything. Not only do the providers and the doctors, the nurses see everything, the patients and their families see everything, because everything is available to them on our electronic patient portal. We have well over 1 million people enrolled on that portal today. They can access their information from anywhere in the world. In cancer specifically, we've begun a pilot with Epic, where we have over 500 patients enrolled now, that they can electronically record their weight, blood pressure, temperature, and electronically communicate with us on a daily basis to make sure that they're doing well, both emotionally, physically, through their cancer care.
Okay, and you're talking about the portal. Does that include the digital apps? We mentioned the digital apps.
So the digital app that we're using now is an Ochsner 2.0 app that allows them, that's our patient portal, to access all of their medical records to communicate with us. But more specifically in cancer, we have what's called Cancer Care Companion, where we are looking at a way to communicate with our patients with a diagnosis of cancer, to specifically look at all of their needs while they're undergoing treatment. But the great thing about Epic is that everyone sees everything, so that if I need a head and neck surgeon, or if I need a psychologist, or a person moves to a different area, they're visiting their children in a different part of the state, I can communicate instantly as if it's the person right next to me through our electronic record. It's absolutely seamless.
And what benefits have you seen for patients by utilizing this multidisciplinary, holistic approach to cancer treatment?
So I think the first thing is confidence that everybody is seeing everything, and that they're focused on them and only them. We're not having to make mistakes that I didn't realize you had this done over here. We can see everything, and with our video visits now, which represent probably about 10 to 15% of all of our visits, we can instantly see and talk to patients, look at their records, look at that together with them to be able to deliver care to them. It's very, very reassuring to patients and their families.
And Kim, there are a couple other elements of this. I mean, the first is knowledge, like Dr. Brooks mentioned, right? And so it's not just the patients being aware of what's going on and what's coming next. It's really their primary care team, because cancer exists along a continuum of our lives, right? And so patients are going to need to transition back to primary care at some point, and we want everyone that's involved in their care, both now and in the future, to be readily aware of what's happening. And this allows it to happen quickly. We're not waiting for faxes to go back and forth, and a fax that sits on the floor of someone's office when it comes in at 5 p.m. on a Friday afternoon, right? I mean, and so I think that's a key aspect of it. I think the convenience is essential. Dr. Brooks alluded to what we're doing with some virtual care. And we had started virtual second opinion programs, virtual tumor boards across the system, and even did some virtual or video visits with patients prior to the pandemic. And it went from a fraction of a percentage of our annual visits to, like Dr. Brooks said, about 12%. So what this does is it allows us to make connections with patients. It allows us to maintain connections with patients to address their issues, so they don't have to get in the car and come all the way into Jeff Highway or to Baton Rouge or Lafayette to see us. They can see us at their place of work. I see a lot of my post-op patients and even some long-term survivors of cancer care. Really, they take a break, they go out in their car, or they go to the break room at work, and they're not having to drive in from the North Shore, which then becomes a 4-hour disruption in your day. And so it's really trying to make the most difficult and harrowing experience of someone's life less painful, more seamless. Make it easier, because we're all trying to give our patients more good days. I mean, that's all any of us want.
Okay. Good. Thank you so much. And let's turn the focus now to equipment and facilities, and also being able to stay close to home. Dr. Brooks, we're going to come back to you. What are some of the cutting edge equipment and methods that Ochsner's using to screen for, diagnose, and also treat cancer?
Well, throughout all of our campuses, we have a tremendous tool chest that we can use, to help our patients. The first thing is knowledge. And our knowledge across our entire system is probably our greatest asset, is that we have instantly at our fingertips the availability, as Dr. Moore said earlier, of specialists in different specialties, that if you have a question, you can simply message them and ask them. And they're looking at the same thing that you're looking at, and you can get back with your patients. I mean, the many cutting edge things that we're doing in terms of bone marrow transplant, soon to be CAR T cells, some of the HIFU that's being done in prostate cancer are really revolutionary for this area of the country, and or being done first here at Ochsner for our patients throughout this area. But I would point out that the number one thing that we have across our system is the availability and the instant availability of the knowledge of a team of doctors, a team of nurses, a team of providers to be able to help take care of you where you are when you need it.
There's one other thing that I really want to highlight here in the technology piece, and that is what we're doing with lung cancer. And so we were the first program in the state to perform robotic bronchoscopy, which allows diagnosis and staging of cancers a little more effectively than traditional techniques had allowed. And so we entered into that space about a year ago. And now we're moving on to the next level of that, which is the ability to identify a tumor, biopsy the tumor, get an answer, find out that it's cancer, and even pivot to a robotic or minimally invasive resection of that cancer on the same day. That team's led by Dr. Brian Pettiford here at the main campus, and is really a focus of pride, for us. I think, as Dr. Brooks, said, many of our treatments are going from more, broader abilities to deliver radiation or surgery to more focal techniques. And that's changed a lot over the last, 20 years. So we're doing a lot of robotic surgery, robotic Whipples, which are big abdominal resections for pancreatic cancer, robotic lung surgery, robotic head and neck surgery. And our radiation therapies are becoming more targeted. And all that does is benefit the patients in terms of fewer side effects, a quicker return to home, and a quicker return to their regular lives.
And Dr. Moore, we understand that Ochsner is also at the forefront of a new blood test, Gallery, that actually screens for multiple cancers. Tell us a little bit about how that works and who's eligible for these tests.
Yeah, we're very excited about this partnership that we announced with Gallery a few months ago. And so this is a blood test that can detect up to 50 different types of cancer. And they're kind of navigating through the final stages of FDA approval. And what we've done with them is able to offer this test through 3 different channels. And so right now it's available in our concierge health program. But what this does, the test is at its foundation, is that it's looking for signals of cancer in the blood using fragments or cell-free DNA, so basically fragments of tumors, and they're looking for certain signals. It's science beyond the level of knowledge of a history major. So that let's just kind of run with that. But they can find up to 50 different cancers in the blood of a patient, typically over the age of 50. That's where it's really been validated. And what we're doing with them is, I started to say, 3 different initiatives. One is our concierge effort right now. The second one, something we're very excited about, is we're one of their national sites for a clinical trial called Pathfinder 2, which is really designed to extend the knowledge of this program and its sensitivity and specificity into more diverse populations. And then the next thing that is on the table and we'll be starting very soon is a project with them called Reflection, which will be run really out of our community health centers. Cancer screening is often disruptive to patients' lives. I mean, I turned 50 this year, so I've entered into a new level of cancer screening, and so you kind of run. It disrupts a couple of days of life. It's hard to get away from work to get some of the tests done. And this is not a way to replace traditional screening tests. It's not a replacement for mammography. It's not a replacement for lung cancer screening if you're a smoker over the age of 50 who smoked more than 20, the equivalent of 1 cigarette a day for 20 years. It's not a replacement for that. It's not a replacement for colonoscopy, but it can be a way to provide some peace of mind, maybe fill in some gaps, and could be a way to identify those patients who need more advanced testing or screening.
Okay. And one relatively new approach in cancer care is precision medicine. What exactly is that? What is precision medicine, and how is Ochsner using that to help patients?
So precision medicine really refers to targeting your treatment to an individual patient. And you look both at the tumor that they have and the genetic aspect of that tumor, but you also factor in the genetic aspect of that individual patient. And so we're attacking this from multiple levels. As a large health system, we would really like to be able to identify those patients who are at higher risk for cancer and then get them into more intensive screening programs earlier. But from a genetic or looking at your own DNA standpoint, we've learned that there are certain drugs that we use to commonly treat cancer that some patients don't tolerate very well, and they end up having side effects, complications in the hospital, which can delay their treatment. And so we're now routinely, and I would say universally, screening patients who are receiving the most common of these drugs for a genetic, I guess it's a genetic change, for lack of a better term, that places them at risk of those complications. And then if they show up that they have it, and this is through our pharmacogenomics program, we're not going to give them that drug or adjust the dosing or handle it more appropriately. And then from a tumor standpoint, and Dr. Brooks and Dr. Pruitt certainly live in this world, is that increasingly we have drugs that are targeted for different signals within a specific tumor. And so it's not just anymore, if you have pancreas cancer, you take this medicine. It's if you could even take the same medicine that has been used to treat a kidney cancer or a head and neck cancer, but it's got these signals. And so as a result of this specificity, this precision, we are seeing improved outcomes.
Okay, and Dr. Pruitt.
You may want to talk on that a little bit.
Oh, yeah, go ahead.
Dr. Pruitt.
Dr. Pruitt.
Oh, yeah. So, yeah, I think that, it's important to know when we go into oncology, we dedicate our careers to learning new things every day. I mean, as Dr. Moore said earlier, it is every day that we get some new treatment. We're kind of seeing the wave of the future in the way we treat cancer. I mean, we used to say, okay, you've got lung cancer or pancreatic cancer. Here's how we treat that. Now we're looking more at the genetic makeup. We're looking at the DNA, the cellular level of the cancer. And we may find a target that kind of presents itself in multiple different cancers. Well, now there are drugs that might just hit that target. So instead of saying, oh, you've got pancreatic cancer, we're going to use this drug. Well, you may have pancreatic cancer and someone else may have lung cancer. But if there's a common mutation, now there's a drug out that could possibly treat that and help with survival. And that's kind of where we're moving in the future. And I always say this to my patients, the more we know about cancer, the more we find out that we don't know. And it's so important to stay on top of the research and continue to work hard to find new treatments for these patients.
Okay, and that was kind of the question that I was going to ask you next is why is it so important for Ochsner to be at the forefront of using these latest tools? But I think you really just answered that.
And I can elaborate on that because, when someone gets the diagnosis of cancer, right? I mean, the minute they hear that word, everything after that is completely missed, right? It's almost like there's another visit that needs to happen so that we can then talk about what's the next step. What are we going to do? How are we going to treat you? For a while, a lot of people would think, hey, maybe I have to leave the state. Maybe I have to go to this big center. Well, now we have that big center. That's what Ochsner is. So no matter where you are in Louisiana, whether you're in Baton Rouge or Dr. Brooks, you're in New Orleans, you're here, we're all communicating. We're all treating cancer the same way. We can all reach out to each other because just like I said, it's a daily learning experience. There may be somebody in New Orleans that knows a little bit more about a disease. I can easily get to them and talk to them about it. So now the patients can stay home, right? It is already hard enough on the psyche, as Dr. Torek would say, and be able to help treat. But to then have to worry about traveling, to be away from family during the hardest parts of your life when you're going through treatment, you don't have to worry about that anymore. You can stay here. We can take care of it right in your backyard.
Okay, yeah, and Dr. Moore and Dr. Torek, I'd love for you to chime in. Like Dr. Pruitt just mentioned, many people do think they have to travel out of state for cancer treatment, but of course, thanks to Ochsner, that's not the case for Louisiana residents anymore. So tell us about the facilities that Ochsner has opened in the last couple of years to really bring top-tier cancer care to Louisiana.
Nick, I'll let you start. I've been talking a lot.
Yeah, that sounds good. I'll give you an exact address. Even I'll say we're in Covington. We're located at the intersection of Interstate 12 and Highway 21 at the St. Tammany Cancer Center. We're rather new to the game. We just celebrated our first birthday in this brand new building, but I'll say we've really connected to the community and continue to grow with the community. And we aim for that comprehensive care and going that extra mile for the patient without them having to travel that extra mile just by being here. One program I'm particularly very proud of is our integrated oncology care. We have a team of registered dietitians, an NP who leads it, a few social workers, and of course, psychologists who really work on managing all the little side effects and little extras that are associated with cancer care. We take the little extras so far just to say that we do have a part of our building that is called Lanyap Care. And that's where we offer all our support groups. We have a wig boutique, acupuncture, some physical therapy as well. And of course, my program with psycho-oncology, where we really address those mental health needs, as Dr. Pruitt said, because getting that news, sometimes we need that second visit. So if we can have someone along the line there we can call up, it's going to help to better prepare the patient and the family for a more successful outcome.
And we're really happy with the new cancer center up at St. Tammany. It's a beautiful building, and there's a lot of great work that goes on in it. And I'm sitting right now in addition to the Gail and Tom Benson Cancer Center here in New Orleans that we opened really right in the middle of the pandemic in 2020, and it added 115,000 square feet, 6 floors, and a lot of space devoted to how we practice cancer care. The clinical space is all set up for multidisciplinary care, so there's rooms that are agnostic to whether it's a surgeon, a medical oncologist, or a radiation oncologist that's coming in there, building in space for those nutritionists, our psychosocial oncologists, and the other experts involved, to come in and visit with the patient. And then bringing in some of what we've referred to as integrative oncology. So we have space for acupuncture here. And it's been shown in evidence-based studies that acupuncture can improve symptoms. So we're not doing this stuff as an alternative to treatment. This complements what we're already doing. Is really designed to help patients feel better and minimize their symptom burden. And it's kind of meeting patients where they are, because many of them are going out in the community and finding these services on their own. So we've made sure to build in some space for acupuncture here in this center and in St. Tammany. We're expanding in Baton Rouge to do the very same thing. Building space for physical therapy and occupational therapy. As a head and neck surgeon, I've worked hand in hand with speech and language pathology or speech therapy for my entire career. And they're essential to getting our patients back to their regular lives. And so, it's the buildings are great, and we very much appreciate the buildings and all the support that we've gotten from the community in offering these services. But it's really the people and the work that goes on in those buildings that I think really differentiates us.
And Dr. Pruitt, what type of cancer treatment is available at some of Ochsner's other facilities, such as Lafayette or even other parts of the state? Can you elaborate on that a little bit?
Absolutely. So, as St. Tammany, we're one of the newer members of the Ochsner family within the past few years. And with that, you get the technology and buildings and newer facilities. So we just built a brand new infusion center. It's state of the art with a new pharmacy, which allows patients to come in and kind of feel comfortable, feel that things are going in the facilities as they are in the research. Everything's new. And so we have that option here. We've also got satellites in places like Abbeville and Crowley, which are a little bit away from Lafayette. So it might be harder for some patients to travel and to get transportation. So we have facilities there where they can get all of their treatment. They'll have a physician there, practitioners, be able to get their infusions. So they don't have to travel 45 minutes down the road to get their treatment, which I think is very nice. Also, one of the things, with Ochsner coming into Lafayette is, we're starting with teaching and bringing in the new generation of doctors so that they can learn. And I think it's good for them. It's good for the patients, but it's also good for us because whenever you get into education, you have to make sure you're staying at the top of your game to be up and with the newest and the latest so that you can teach the next generation how to take care of patients as well.
Awesome. Well, let's talk about the medical treatment and the clinical trials that are happening. Dr. Brooks, what is Ochsner's approach to clinical trials? How many cancer trials does Ochsner have in progress at any given time?
Well over 100, even more than that. And it's woven into our clinical practice. So I'm going to give you an example in the medical oncology world where I live. So about 4 years ago, we incorporated into when we write our chemotherapy orders, which we have standardized across the system so that from a quality and a safety standpoint, anytime a patient receives any treatment across our entire system, it's the same. And everybody has looked at it and agreed to it. And that's a really, really important part. So what we've done is we've integrated what are called our pathways, where we will put into all the characteristics about the patient's tumor. And about a quarter of all cancer doctors in the United States have agreed to a certain pathway to treat patients. When we put that information in, the first thing that pops up is our research trials. So that we have to answer, is the patient eligible for a research trial? If not, why? And so that we can record that so that we are always looking for new ways to treat patients with a particular cancer. And as we move through the patient's illness, we continually monitor that. So we also monitor our physicians to see how well, wherever you are in our system, how well you are adhering to the pathways, which are the agreed upon ways to treat patients, and to see how well we're using the research trials to take care of you. It's a truly, truly wonderful way to manage patients the same way across our system so that patients get the very best care wherever they receive it.
Dr. Brooks hit the nail on the head. I mean, for us, clinical cancer care and clinical trials are inseparable, and we're really trying to further ingrain this in our workflows, if you will. We participate in a regional NCORP, the Gulf South, what's called the Gulf South NCORP, NCORP. It's through the National Cancer Institute, and it's in partnership with pretty much all the other cancer centers in Louisiana. But this has what we call late phase clinical trials, so drugs that have already been proven in early phase efforts, but also innovations to help quality of life and other aspects. And so we have been participating in that for the last several years. And in fact, we were one of the first sites in the country to have one of these community oncology research programs dating back to the 80s. I think more importantly, 5 years ago, we stood up what we refer to as the Precision Cancer Therapies Program. And I apologize for not mentioning this earlier, but this is our phase 1 program. In cancer research terms, that means these are the first time that some of these drugs are used in humans, or first time they're used for a particular indication. And so this is where that precision piece comes back into play, so that we are able to through the context of clinical trials, identify a drug or use a drug that has traditionally been used for another type of cancer for something that's just emerging. We have partnerships with industry, and currently with an entity called TGen, or Translational Genomics Institute, out of Phoenix, that helps identify really promising agents. And we've seen some fantastic long-term responses and survivors that have done really, really well through that phase 1 program. So again, it's really trying to offer that full menu of clinical trials, not only in the medical oncology space, but also in the surgical oncology space, and increasingly within radiation oncology too.
Okay, and let me ask this. Some people may worry that if their physician suggests that they participate in a clinical trial, that means they don't have any other options. However, we know that's not often the case. So tell us a little bit about how you determine if a patient is a good trial candidate, and how do you approach that conversation?
Well, everybody's can participate in clinical trials. Now, everybody should be considered. Now, whether or not you are strong enough from your other medical conditions to participate, that's a separate issue. But every patient should be considered to be in a clinical trial, because you're not just getting my opinion, Ochsner's opinion. This is the opinion of leading researchers from around the United States and really around the world to try to give the very best to our patients. So there are 3 phases of clinical trials. As Dr. Moore said, phase 3 is the most advanced, where we're usually comparing treatment A to treatment B. I'll give you some examples. In my career, many years ago, patients with very early stage breast cancer and colon cancer received no treatments after their diagnosis. And through these phase 3 trials, we now can target which patients best benefit from treatments. And the research done here at Ochsner, along with other physicians around the country, has changed the way we treat breast and colon cancers in early stages. I mean, that's something that we have done for many, many, many years, and it's revolutionized the way we treat people. We figured out which patients don't benefit from treatment, don't need treatments, and which ones do. That's a phase 3 trial. A phase 2 trial is where drugs are being given to a patient with a specific disease to see how well the drug uses, how well the drug works. And in phase 1 trials is where we are giving it to the first group of patients. But what you have to understand is, with the precision medicine, the genetic analysis of cancers, these phase 1 and 2 trials have been revolutionized, so that we're just not giving, you're not a quote, a guinea pig. You actually have the molecular characterization of a tumor that allows us to give precision medicine to you to see whether it works. It's truly been a revolution in the way we've taken care of patients over these last several years.
The fascinating thing about clinical trials too, Kim, is that there's a large body of evidence that shows patient outcomes, like survival and tolerance of treatment, and really the things that people really care about are better when you're on a clinical trial. And a lot of that comes just in that there are more touch points, more arms wrapped around you, as you're going through the course of treatment. And so, it's been shown to improve outcomes. And so we're proud that we have such a rich armamentarium of clinical trials. And again, I think all patients, are eligible. And sometimes what we're seeing now with some of these new drugs is we're looking at sequencing things. So is it, instead of just going right to surgery, should you have some immunotherapy or chemotherapy before surgery, or should we do that before radiation or after? And so this is where that multidisciplinary team comes into play. Things like the multidisciplinary tumor boards, which we have set up by disease site across the system, such that if Jay sees a patient with head and neck cancer in Baton Rouge, that he can present him, and me and my partners here in New Orleans can weigh in. It identifies again patients for clinical trials. That's another avenue for doing that. We have essentially a clinical trials tumor board and a molecular tumor board where if Dr. Pruitt had a patient with say pancreas cancer with a certain molecular or genetic signal, he can present it to Dr. Mark Matrana's molecular tumor board and see if we have a clinical trial available for it, or see if there's a trial out there that we could perhaps bring and open up and make that connection possible for the patient.
Okay, and Dr. Pruitt, many people have missed their cancer screenings over the past 2+ years, really, because of COVID. What steps can they take to get back on track and have those screenings scheduled? And again, why is this so important?
Yeah, and I mean, I think, this brings up a good point, right? So everyone here, any oncologist in the world would agree that this field of medicine is tough. I mean, it brings its own challenges. We're dealing with patients at their most vulnerable time. And it was tough pre-COVID. And then you bring in a pandemic, and the new challenges that you have to navigate as a provider is it can be very tough and daunting. I mean, you heard people touch earlier on, maybe we can give patients less treatment. And now with the pandemic, we're trying to say, okay, maybe can we scale back on how much treatment patients get? Is that possible? Clinical trials are the things that allow us to see that, so that maybe they're not immunosuppressed as long. But screening is also one of those things that allows us to catch cancers early. The earlier you catch the cancer, the better we are to treat it, the better chances we have to cure it. And sometimes we can decrease the amount of cytotoxic drugs or chemotherapy, things that will suppress your immune system, and still get the same result. And so I think there was probably close to 70 or 80% drop in screening since 2020. And it's just because of the fear of getting out there. But now we're I'm not going to say that COVID's gone, because it's not, it's here forever, but we're moving to where we've got vaccines and we've got great things to help make the disease and the illness from COVID milder. So get back out there, get with your primary care physician, talk about screening so that you can get back into getting the procedures done that will help you find cancer early, so that we can help treat you at an earlier stage and possibly, prevent some of the long-term effects from certain drugs that you may have to receive. So if we catch it early, it could be surgically removed only. So screening is so important. And I think it starts with your primary care physician, and just getting out there and asking for the resources. There's plenty of resources for screening. I mean, there are now programs that do mobile mammograms. So you don't have to necessarily go to a place. The mammogram will come to you, or to your community if you don't have a big facility for screening in your community. So these are all important things, and I'm glad we're seeing the.
Uh-oh.
Uh-oh.
Oh no.
I think we got on Dr. Pruitt there.
Oh, I'm not here.
Oh, now you're back.
I'm back.
You're back.
Okay.
So patients can ask their primary doctor, about these mobile screenings and about, how to get to the screenings where even if it's not going the way they used to get screened, there are new avenues to do that now in this COVID era.
Yes. Yeah. I mean, and even before that, I mean, it's getting as many people screened as we can is how we help to catch cancer earlier. And so, I mean, there's been programs that have been out there with Ochsner to help get screening out to the community, right? And so I think that now in the post-COVID era, it's even more important to do that so that people feel comfortable going back to getting their annual screenings, so that we can really try to take care of you the best that we can.
Yeah, we've really leaned in this space, Kim, in the last few years. We, in partnership with St. Tammany, we send their Be Well bus across the North Shore, trying to incite interest, knowledge, and execute some cancer screening. We, in partnership in Shreveport, they have several mobile vans that go out to very rural communities and provide mammography. Increasingly, it's colon cancer screenings through FIT kits or the stool sampling, or even I guess the stool sampling kind of techniques. A lot of education around other cancers, again, like head and neck cancer. I think this is where we, as an integrated health system with a large footprint, also stand to make a point about vaccination and cancer prevention. And so there are at least 4 cancers that are caused by the human papillomavirus, and there is a vaccine for that. And so that's cervical cancer in women, anal cancer, and then 2 of the most common head and neck cancers. In fact, the head and neck cancer piece of that is now the most common HPV, or human papillomavirus related cancer. And these cancers are preventable. My son's just turned 11 and we got them vaccinated for this. They're not really happy with me right now, but hopefully in 30, 40, 50 years, they will be. If we do our job right, we would like to go out of business. I want Jay Brooks to get some hobbies. I would like to, and so we need to vaccinate. We need to stop smoking. Obesity is one of the leading factors for cancer development. And so, and unfortunately, Louisiana and the Gulf South leads the United States in obesity rates. And so be active, smartly manage your diet. All these things can help prevent cancer. Not one thing. I mean, this is cancer in effect is a gumbo. And so everybody makes a different gumbo. It's like a dad joke. I'm sorry, but I mean, that's the truth of the matter. And so just saying, lose weight, stop smoking doesn't mean that you're not going to get cancer. But these are all levers that we can pull in our own lives. Be active, exercise, eat right, don't smoke, get vaccinated. Vaccination for HPV goes up to age 45 now. It's been approved. And then when you come of age, those of us that are 50 or 45 or 40, depending on the scenario, get your mammograms, have your colon cancer screening, whether through colonoscopy, FIT kit testing, Cologuard. It's really whatever screening you get done is fantastic. We're curious to see how this GRAIL or Gallery test plays out over time. But as Dr. Pruitt said, the earlier we find your cancer, the better you're going to do. And the best kind of cancer you get is the one you never get. Absolutely. Or sunscreen too, by the way.
Yes.
So everything that Dr. Moore said, I agree with. I mean, smoking represents about 25% of all cancer, obesity about 20%, decreasing alcohol consumption, doing the screenings, doing the vaccinations. And so people will say to me, okay, so I've done all this. So does it really work? And I can now tell them it absolutely works. So if you every February, the American Cancer Society comes out with their deaths from cancer over the last several years. And so in the last 7 years, cancer deaths in the United States every year have fallen 3%. So that's a stunning number from a public health standpoint. And so our effects with tobacco cessation, screening, treatments have really revolutionized and have made cancer a chronic disease. Many years ago, I used to give a lecture when we had our board review course. And I used to say that people with lung cancer, unfortunately, the vast majority of them would die of their lung cancer within a year or two. Today, 35 to 40% of people with widespread lung cancer are alive 5 years after their diagnosis. And the reason for that is some of the new immunotherapy drugs that we've introduced. So cancer is not a single disease. It's a multitude of diseases. We have learned to really target these diseases with specific agents. We've caught them earlier now as well, and patients live with their cancers through their lifetimes. And it's not uncommon for me to see patients who have a second or a third cancer. So it's very, very important to realize that we have made major strides in the diagnosis and treatment of cancer so that people are living longer, happier, productive lives.
Yeah, and I just want to make one other point to Dr. Brooks, and I think it's so important for people to understand you hear it all the time in the general public. When are we going to find a cure for cancer? Cancer is not one disease, right? Cancer is a ton of diseases, and we cure some cancers, and we're getting better at treating it. But there isn't going to be a one cure-all, right? It's going to be, like everyone has said, lifestyle changes, screening, research to find new drugs, but understanding that this isn't one disease, right? The guys here, any oncologists throughout the country, we dedicate our lives to treating a multitude of diseases, right? It is multiple diseases all under one umbrella called cancer. And I think that's so important for people to understand because, like Dr. Moore had said, some are caused by viruses. If you can prevent the virus, you can prevent the cancer, right? Others, not so much. We don't know what causes it. So we're getting there and we're working hard. And every single day that we come to work, it's not only just for the patients that we see, it's for the patients all throughout the world. We read, we learn, and we research to try to get better.
And Dr. Torek, specifically relating to the mental health treatment and the counseling for cancer patients, how would you say cancer care at Ochsner has evolved over the last few years? I guess what are some of the common misconceptions or myths about cancer treatment?
Well, I'll get into the misconceptions and myths here in a second, but to piggyback more off that statement from everyone in this group here, I'll say really it's that team effort, and it's that really looking at that, what's the behavior? What are the thoughts that are going? What's driving this? And that's where someone like me or my colleagues, we pop in and we do our best to really address those psychological aspects of the diagnosis or things that might contribute to the second or third cancer or even prevent it in the first place. This whole management of diagnosis, treatment, and survivorship is relatively new here in Louisiana. But as the data states and as patient outcomes show time after time, it's very necessary. And I'll say, to talk a little bit more about trials and tumor boards and such, my psychological colleagues and I, we're right in those meetings. And if we're reviewing someone, we go, all right, well, this is something we can impact from the patient side of things, where we can look at their behavior, or maybe there's something cognitive going on. We could do a little testing and see how we might be able to support from a neuropsychological perspective. Really, though, this is aimed at the patient, but also their caregiver, their family, and focusing on the treatment of the whole person rather than just the disease, managing throughout.
And talk a little bit about those common misconceptions and the myths about cancer treatment. And Dr. Brooks, if you want to chime in too, that would be awesome.
Well, I'll say before Dr. Brooks hops on, it's pretty much standard procedure for anyone at St. Tammany Cancer Center to visit with one of our psychologists. And that doesn't mean that you're crazy right off the bat. I often let patients know that in the first visit. This is adaptation to care and how we can learn to best serve you and have you be a member of our team, because really we all come together. So I'll let him take it from there, though. Sorry for cutting you off.
So most people think of cancer equals death equals pain, and that's not true. The number of people alive with cancer today and living productive lives is just astounding. Some of we have a disease that used to end a person's life in 3 years. A few years ago, we now control with a pill, one pill a day, and we have 250,000 people alive in the United States with that. That's just one example. So the number of people living with a previous diagnosis of cancer is just unbelievable. I think people are frightened. I think sharing their experiences with others is really important. We have support groups, and some people like that, some people don't. I think that's a wonderful tool. Every patient that comes into our practices on a regular basis receives a screening to see how well they're dealing with cancers. And those patients then we escalate to make sure that they have the proper individuals to talk about what is this doing to them, to themselves, their livelihoods, their families. And so it's an entire holistic approach in caring for patients that we bring to our patients across our regions.
Kim, I'd throw out one more misconception. Increasingly, we are engaging with palliative care experts in the co-management of our cancer patients. And so I think a common misperception, even in the medical community itself, is that palliative care equals end-of-life care equals hospice. And that's entirely not true. Palliative care is symptom management. And so if you have early stage cancer and you have symptoms, we have experts that can help manage those symptoms and help you lead a more productive life, whether it's pain, poor sleep, fatigue, anxiety, whatever that is. We have the teams to do it. And so what we're trying to do is move palliative care up into earlier phases of treatment. And I think overcoming that misconception, both within the community and I think still importantly within the medical community, is essential and something that we're all working to do.
Okay. And finally, Dr. Moore, what is the best way for someone to find an Ochsner oncologist or physician?
If you're not watching the show right now, the best way is to go to www.ochsner.org /cancer care, and you can learn a lot about our programs there. We also have a presence on different social media channels where you can follow our activities and see when we're going to be in your community doing screening events and whatnot. We do have a big event. We're contributing rather to a big event with the Urban League in New Orleans on Saturday, September. I'm trying to think when I'm not on call. I think it's 17th. So September 17th, our team will be down there talking about cancer screening, education, prevention, vaccination, as well as the importance of clinical trials in cancer care. And so that's the next event, of which I'm aware there may be some on the North Shore, there may be some out in West Louisiana as well. But the best way to find an Ochsner doctor is go to our website and search under cancer care.
Okay. Is there anything else anyone wants to add? All right. I think that is it then. That will do it for today's town hall. A big thank you to all of our panelists, Dr. Moore, Dr. Brooks, Dr. Pruitt, Dr. Torek. We appreciate your time, and we want to thank everyone who joined us for this very informative town hall. You guys are attacking it from all different angles and continue to do a fantastic job. And people in Louisiana, as you said, can stay right here for cancer treatment and get top tier cancer treatment. So we certainly appreciate your time today. For more information, again, on cancer services at Ochsner, visit www.ochsner.org /cancer care. And you will find all the information you need. In the meantime, I am Kim Holden. I hope you all have a great day.
Thanks, Kim.
Thanks.